Welcome back to another masterclass. I'm Dr. Naveed Zafar, clinical physiotherapist. Here is something we don't talk about enough in PT school. We spend years learning muscles, joints, special tests, and almost no time learning what's sitting in our patient's medicine cabinet. But here's the thing. The drugs your patient is taking can completely change your treatment plan. Sometimes they mask symptoms, sometimes they create red flags that look exactly like a normal MSK injury, and sometimes if you don't ask about them, you can actually hurt your patient. Today, two cases, both look completely routine on the surface. Case 1. A runner with heel pain sounds simple, right? Wait till you hear his medication history. Case 2. A cardiac rehab patient who just won't get his heart rate up no matter how hard you push him. Is something wrong with his heart or is something else going on? Let's get started. Quick reminder before we start, in PT school we are trained to ask, how did this happen? The mechanism of injury, but how many of us are trained to ask what medications are you on and for how long? Not many. That is a gap because certain drug classes interact directly with the tissues and systems we treat every single day. Steroids and fluoroquinolones affect tendon strength, beta blockers affect heart rate response to exercise, anticoagulants affect how aggressive you can be with the manual therapy. Statins can cause muscle pain that looks exactly like an overuse strain. Today we are covering two of these, one tendon, one heart rate. Keep the meds list in mind as we go. Alright, case 1. A 52-year-old male presents to outpatient PT with a 4-day history of posterior heel pain that worsens with push-off. He resumed jogging 1 week ago after finishing a 10-day course of Levofloxacin for pneumonia. No trauma, no palpable gap. Thompson test is negative, but he is tender 2 to 4 cm above the heel and can only manage a painful single-leg heel raise. What is your next step? Option A, begin the Alfredson eccentric loading protocol today. Option B, clear him for full running, no change is needed. Option C, hold all treatments, refer for MRI first. Option D, reduce load, address the medication related risk, monitor closely. Alright, pause it here. If you want to work through it yourself, I'll wait. Alright, let's break it down. Option A, starting the Alfredson protocol right away. I get why you would pick this. Mid-portion Achilles pain, no rupture on Thompson test. Textbook answer is heavy slow resistance or eccentric loading. That is literally what we are taught for Achilles tendinopathy. But look at his history again. He just finished a course of Levofloxacin, that is a fluoroquinolone antibiotic, and fluoroquinolones carry an FDA boxed warning for tendinopathy and tendon rupture. Loading this tendon hard right away with the standard aggressive protocol, that is risky here. This is not your typical overuse tendinopathy. Option B, clear him for full running. This is the safe reassurance trap. New graduates pick this because Thompson test is negative, so no rupture, so he must be fine. Thompson negative only rules out a complete rupture. It tells you nothing about a partial tear or how much more vulnerable this tendon is right now because of the antibiotic. Send him back to full training load with zero modification and you can turn a partial injury into a complete one. Option C, hold everything, refer for MRI before touching him. I know this feels like the responsible choice, but think about it. He has no red flags for rupture, no palpable gap, no sudden pop, Thompson negative, and he can still manage a heel raise even if it's painful. Ordering imaging on every at-risk tendon with zero rupture signs is not good clinical reasoning. It's avoiding the decision, it delays care, and it's not what the findings here are telling you to do. Option D, this is your answer. Here is why. You recognize this as a Fluoroquinolone-Associated Tendinopathy. This isn't a folklore, it's a well-documented drug reaction. Quick concept and I'll keep it simple. Fluoroquinolones bind to magnesium in the body. Tendon cells need magnesium to properly build and organize collagen. So for a window of time during and after the course of antibiotics, the collagen in the tendon is genuinely weaker than normal. That is why this isn't just tendinopathy, the tissue quality itself is compromised. So what do you actually do? You don't discharge him and you don't blast him with aggressive loading either. You start conservative, pain-free or low pain isometric holds first before progressing to anything eccentric or high load. Cut the running out temporarily and you educate him. He needs to know the warning signs of a worsening injury, sudden sharp pain, a pop, inability to push off, because if any of those show up, he needs to be seen urgently. And one more thing fresh graduates forget, loop back to the prescribing physician. A quick note, this patient recently finished a fluoroquinolone and now has tendon symptoms. That is valuable information for his whole care team. So, Here's your takeaways. Number 1. Fluoroquinolones, ciprofloxacin, levofloxacin, moxifloxacin all carry a boxed warning for tendinopathy and rupture. Achilles is the most common site, but it can happen anywhere. Number 2. Risk goes up with age over 60 with corticosteroid use and in kidney, heart or lung transplant patients, but don't assume it can't happen to a younger, healthy patient. It can. Number 3. Ask about recent antibiotic use in every single new tendon pain case, not just did you twist or did you fall. Ask about medications every time. Number 4. A negative Thompson test rules out complete rupture. It does not clear the tendon. If your patient has a risk factor like this one, modify your loading progression. Don't jump straight to the aggressive protocol. Alright, that is case 1. Now, completely different case, completely different drug class. This time we are not talking tendons, we are talking heart rate, and this one trips up almost every new graduate working in cardiac rehab or even general outpatient with older adults. Case 2. A 64-year-old male 3 weeks post-MI is referred to outpatient cardiac rehab on Metoprolol, aspirin and atorvastatin during treadmill training using the Carbon formula for his target heart rate zone. His heart rate barely climbs above 95 beats per minute, well below target, even though he's breathing heavily and rates his effort 15 out of 10 on the Borg scale. What is your next step? Option A. Increase intensity until he reaches the target heart rate zone. Option B. Stop the session. Suspect a cardiac event. Option C. Hold rehab. Refer to cardiologist first. Option D. Use RPE and the talk test instead of HR zones. Pause it here. If you want to work through it yourself, I'll wait. Let's break it down. Option A. Pushing him harder to chase that calculated heart rate zone. This one's genuinely dangerous. His 3 weeks post-MI, if you keep increasing intensity because a formula says he should be higher, you can push him into real cardiovascular overload while his heart rate reading tells you everything looks fine. That is exactly the trap. Option B. Stopping the session. Assuming something's wrong with his heart. I understand the instinct. A low heart rate response feels alarming if you don't know why it's happening, but a blunted heart rate response in this case is expected. It's not automatically a red flag. Stopping every session out of panic isn't clinical reasoning. It's reacting to a number you haven't connected to his medication list yet. Option C. Hold rehab, send him to cardiology first. Again, this feels like the responsible move, but if this is simply the known pharmacological effect of his medication and nothing else in his presentation is concerning, you don't need to halt his rehab and refer out. That just delays his recovery for no real reason. Option D. This is correct. Let me explain why. Look at his medication list again. Metoprolol, that's a beta blocker. Quick concept refresher. Normally when you exercise, your sympathetic nervous system releases adrenaline, which binds to receptors in your heart and tells it to speed up and pump harder. Beta blockers sit on those same receptors and block that signal. So even though his muscles are working hard and demanding oxygen, his heart physically cannot respond the way it normally would. His heart rate simply cannot climb the way an unmedicated heart would, no matter how hard he's working. So, what does that mean for you as his physiotherapist? Heart rate just became an unreliable measure of his exercise intensity. Age-predicted formulas, Carbon, all of it, built on the assumption of a normal heart rate response, throw that assumption out. Instead, use RPE, the Borg Scale, 60 to 20, and aim for somewhere around 12 to 14, somewhat hard. Pair that with the talk test. If he can talk in short sentences but couldn't sing a song, that is a solid moderate intensity marker. Neither of these tools depends on heart rate at all. And you still watch everything else, his blood pressure response, any symptoms like dizziness or chest discomfort, his overall tolerance. Heart rate alone just stops being your primary guide. So, your takeaways: number 1. Beta blockers blunt the heart rate response to exercise. Both resting and exercising heart rate will run lower than you would expect. Number 2. Never rely on age-predicted heart rate formulas alone in a patient on beta blockers. The numbers will lie to you. Number 3. Use RPE and the talk test as your primary intensity guide instead. Number 4. A blunted heart rate response by itself is not a red flag, but keep watching blood pressure response and symptoms. Those still matter. Alright, let's bring it together. In case 1, a runner's heel pain that wasn't just overuse. A recent course of fluoroquinolones changed the whole risk picture and the treatment plan had to change with it. In case 2, a cardiac rehab patient whose heart rate wasn't telling the full story because his beta blocker was blunting the response completely. Two completely different systems, same lesson. Always check the medication list. It's not extra work, it's part of your clinical exam. Comment below which one surprised you more, the tendon case or the heart rate case. If this helped you, subscribe, hit the bell and share it with a colleague. I am Dr. Naveed Zafar. See you in the next one.